Good afternoon, good morning, welcome everybody. Welcome to Bridging the Gap, Integrating Mental Health and Hepatitis Care, our No Hep Medical Visionaries webinar. We're just going to give it a couple of minutes to let people filter in. So just bear with us a minute, and when the numbers start slowing down, we'll start the webinar. Fantastic. I think the numbers are slowing down now. So welcome to everybody. Thank you so much for joining us today. We are really looking forward to presenting this webinar and sharing this webinar with you. I'm going to do a little bit of housekeeping first. Next slide, please. Oh, just to say, we are only able to put this webinar on today. So thank you very much to AbbVie who've supported this. Next slide, please. Okay, this is our standard. We have translators on available today. So you will see it on the next slide. So we have Spanish and French. There is the interpretation circle on the bottom. Just go to that and choose the language that you would like. We are consciously trying to speak slowly so that the translators can translate all right. Next slide, please. Okay, so for anyone who's attending and doesn't know, don't normally do this, but we're going to do this today. We are the World Hepatitis Alliance, so we are an international network of over 400 civil society and community organisations working in over 120 countries, all working towards the goal of eliminating viral hepatitis by 2030. So we are lived and governed by people with lived experience of viral hepatitis. And we ensure that people with lived experience are at the heart of everything we do. Next slide, please. I'm just going to do a little bit about viral hepatitis, just so that we can be mindful when we move forward and talk about the integration and the connection between mental health, that hepatitis-related deaths have increased by 1.3 million in 2022, which was up from 1.1 million in 2019. 254 million people worldwide are living with chronic hepatitis B and 50 million living with chronic hepatitis C. So, and this is the thing about it, only 13.4% of people living with B have been diagnosed, with only 2.6 receiving treatment. And with hepatitis C, only 36% of people have been diagnosed, and only 20% of those are receiving treatment. Next slide, please. So the No Hep movement, which is it's really exciting to present this slide. It's been years since I've seen it. It was launched in 2016, and there's one picture there. We were sat by Eros when we launched the No Hep campaign. It's a global new movement which unites governments, medical professionals, patients, and the hepatitis community to eliminate viral hepatitis by 2030. Next slide, please. So more recently, and I'm just not 100% about the date, so a few years later, the No Hep Medical Visionaries program was launched. And it was actually a previous president. I didn't actually introduce myself. Sorry, my name is Rachel Halpern, and I am actually the president of the World Hepatitis Alliance. But it was a previous president, Sue Wang, who led the start of the Medical Visionaries program, which has just been incredible. We've got over 700 medical professionals who are members now. And it was set up as a peer-led program, which kind of was aimed at equipping medical professionals with the knowledge and tools that they need to lead the fight against viral hepatitis. And it was about empowering them to advocate and to act to drive, the elimination efforts. And for us as patient groups, having this group of committed professionals is just incredible. And the work over the years has been amazing, and it's built really, really quickly. Next slide, please. So I'm actually really delighted to say that last year, I think it was, we expanded the program. to include mental health professionals and addiction specialists, because they're absolutely key to reaching elimination goals. You know, we know that in a lot of high income countries, you know, addiction is one of the highest prevalence of transmission routes for hepatitis C. So as part of our expansion work, we worked with key opinion leaders within the mental health and hepatitis healthcare space to develop education and advocacy resources that are relevant for mental health care professionals. And that's really, we're going to be talking a little bit more about this today and how it interplays. The resources that we have, they talk about and they highlight the interplay between mental health and viral hepatitis, particularly hepatitis C, integrating viral hepatitis testing into mental health services. And it's really only the last few years that we have been talking about this. Linkage to care, stigma in the healthcare settings. We actually held a webinar probably about 4 weeks ago with community members talking about mental health and the impact of mental health on those with viral hepatitis, and stigma really high within that. And then, you know, some information around who to test and how to test for both hepatitis B and hepatitis C. So enough of an introduction, and I hope that's given you a brief overview, but just really wanted to say, that you need to know, if you do want to download any materials, there's a QR code there. You just put your camera up on your phone and you can, it will take you directly to where the resources can be downloaded. But for today, we're talking about integrating mental health services and hepatitis care. And it's really become increasingly essential. You know, we know that studies have shown that people living with severe mental illness have an increased prevalence of hepatitis B and hepatitis C in comparison, that is, to the general population. And this can be attributed to the fact that severe mental illness is associated or can be associated with behaviours that can lead to the transmission of viral hepatitis, including injecting drug use. So screening in mental health care settings for viral hepatitis, whether that's inpatient or community care, is a really important part of a comprehensive hepatitis elimination response. So today I'm absolutely delighted to have three professionals, three experts with us, and we're going to explore the efforts to bridge that gap between hepatitis and mental health care. And hopefully we will share newly developed resources designed to equip mental health professionals with accurate, relevant and practical information on hepatitis testing and treatment, discuss some best practice in implementing integrated service, and explore implementation barriers and perhaps how best to overcome them, and the role of advocacy in improving these services. So we have, as I've said, I've got three incredible panelists here today. I wondered if you'd like to introduce yourselves. Renee, would you like to introduce yourself?
Certainly, and thank you for having me. I am Dr. Renee Logan. I am a GP or a family physician who works currently as a hospitalist at the Center for Addiction and Mental Health in Toronto, Ontario, Canada, where I provide medical care for patients who have been admitted for severe mental illness under the care of a psychiatrist.
Fantastic. We're delighted to have you with us today. Thank you. Professor Christoph, would you like to introduce yourself? Oops, you're on mute. Oh, we seem to have lost your sound. Oh no, it worked just now. Shall I go to Dr. Anastasia while you're sorting your sound out? I'll come straight back to you. Dr. Anastasia, would you like to introduce yourself?
Yeah, good afternoon, everyone, and thank you for invitation. I'm a doctor, psychiatrist, actually Ukrainian psychiatrist, currently working in Poland. I work at Drivnica Hospital near Warsaw and teach at the Medical University of Warsaw. I'm also a PhD candidate in Ukraine and a member of the EPA Early Career Psychiatrist Task Force. And thank you for opportunity to talk on this webinar.
No, thank you for coming and sharing with us. Professor Christoph, is your sound come back? Oh dear. We can come back in a minute. Maybe we'll start some of the presentations, and then hopefully by the time you're presenting, it will have, okay. I think maybe Ben, I know you're there behind the scenes. I don't know if you'll be able to help at all. That would be great.
I'm just
Yeah.
talking to them now.
Lovely, thank you. Okay, so just the format of the webinar is we have some short presentations, but to provide a bit of background, then we have some questions, but also there's an opportunity for you guys to ask questions. There's a Q&A box, or please, if you would like to, and just share comments or conversations between you, there's a chat box. We will try and leave some time at the end for your questions. So it gives me great pleasure to introduce back to you, Renee, Dr. Renee Logan, who's going to be talking to us about integrating hepatitis care into mental health settings, and it's a case study. So over to you, Renee.
Okay. Can you confirm you can hear me and see my slides?
Yes, we can hear you and see your slides.
Great. Okay. So thank you. I'm going to talk briefly about how we are advancing and integrating care into our mental health and addiction setting. First of all, some background to let you know that I work at the Centre for Addiction and Mental Health in Toronto, Ontario, Canada. It's Canada's largest mental health institution located in downtown Toronto. It's a 500 plus bed hospital with a 24/7 psych emergency department, as well as a variety of outpatient psychiatric services. So here in Ontario, we have, as I think many people around the world, have a shortage of primary care providers, whether they be family doctors or nurse practitioners. And as of 2024, 16% of our population in our province did not have a primary care provider. And what we know is that marginalized populations are even less likely than the general population to have a primary care provider. So when patients are admitted under the care of their psychiatrist in our facility, we have hospitalists who are GPs, family doctors, depending on the terminology you use, or nurse practitioners. They provide medical care for patients while they are admitted to hospital. And in 2023, we published some data from our institution. We took a look at records from 2017 through 2021, examining the rates of hepatitis C testing and treatment and follow-up. Of 1,000 patients in our chronic care facilities, we screened 63% for hepatitis C over that time frame. And we found hepatitis C antibody positivity at 4.9%. We found that 15 patients over that time period were eligible for treatment for hepatitis C. And we have had training, the hospitalists have had training for on-site treatment for hepatitis C. But each hospitalist will decide what to do and how to manage patients, partly patient preference, partly hospitalist comfort level. And what we found was that of the 15 who were hepatitis C RNA positive or eligible for treatment, that 8 were referred for specialist care and 7 were treated on-site by the hospitalist. And what we found was that 5 who had been referred didn't show. 3 did show to their specialist care and were treated. And 1 of those completed their SVR testing, which is the test of cure. And if we look at the on-site treatment group, 7 were treated, 6 did their test of cure, 1 did not complete their test of cure. So what we take from this is that on-site treatment is certainly more effective than referring to specialist care. So when we think about opportunistic care, caring for patients where they are at, patients with severe mental illness have very limited contact with the healthcare system. There are many barriers, including patient, provider, and system factors. There's an opportunity during an inpatient stay for each patient, as they're seen by the hospitalist, to have many medical issues addressed, and even to be referred to specialists, and if possible, to reconnect with primary care providers that they may have had in the past. We know that direct-acting antivirals are covered for virtually all patients in our province, either through private plans or through provincial plans. So there is no one who would be not able to get a direct-acting antiviral for the treatment of Hep C. So our hospitalists, by routine, offer all patients who are admitted to our hospital screening for STIs and blood-borne pathogens. We know that patients are aware of their Hep C status. Some are aware they have Hep C. If not, then they're certainly aware of their risks, but they have been uncertain how to access care. That's the feedback that we get from our patients. Some of the challenges that we face when patients are in hospital is that their length of stay is quite short. So on our acute care units, for instance, it can be inside of 2 weeks. And there's a delay in getting lab results. The way it works in our facility is we send our lab results to the public health lab, and results returning often exceeds a length of stay, which can lead to disruption. And when we do refer to liver clinic, we hear and we know from our director of liver clinic close by that we have a very high no-show rate from our hospital, depending on the year, somewhere between 75 and 95% no-show to the clinic. So what we opted to do, I worked with Dr. Jordan Feld from the University Health Network here in Toronto to design a randomized controlled trial, which I won't go through in its entirety, but suffice to say that we're looking at the question of, does treatment initiation at CAMH versus the standard of care, which has typically been to refer to specialty clinics, help improve patient recovery? And as part of this, we actually were able to, and lucky enough to be able to introduce point of care testing. And so when we order our admission lab work for patients, we are able to offer them a point of care test, which of course gives us an answer within minutes as to whether they are antibody positive. So while this randomized controlled trial is underway, some interesting things have happened. So we have educated the entire hospitalist complement in the diagnosis and treatment of hepatitis C, and they've actually carried this. Some of our hospitalists work here part-time and have primary care practice or addiction work that they do elsewhere, and they've carried this education to other places, which is wonderful. There's increased institutional awareness in our facility, awareness that hepatitis C is a treatable and curable illness. And what that has meant is incredible institutional support. So currently underway, I have funding from the Health Science Academic Network to do a quality improvement project in our outpatient addiction setting, looking at introducing point of care testing and treatment when patients attend an outpatient addiction clinic in our facility. And we are in development for a second QI project in our outpatient schizophrenia clinic, similarly to be able to provide testing and treatment on site for hepatitis C. What's happened in the last few weeks is that someone has reached out to me to ask if we can develop a project for our emergency department. So the fact that we talk about this, that we present on it, has led to this fantastic support from the institution with regards to hepatitis C. So my takeaways are this is quite doable work. Point of care testing really reduces barriers It allows for timely counseling and treatment initiation. It's so important to treat people where they are at, and when they have a touch point with the healthcare system during an admission is a great opportunity to be able to test and treat. A team-based approach is really important. So we need to involve everybody from nurses to allied health prescribers and pharmacists all work together. The QI work has been really informative and has led us to develop a training program for all addiction nurses. They have all gone through it, where they have learned pre-test, post-test counseling, and the performance of point-of-care tests, which they do now for patients attending the addiction clinic. We've developed lab order sets, which really help the prescribers. Our prescribers may be nurse practitioners, primary care addiction providers, and psychiatry addiction providers. So we have an order set to help people remember all the bits and pieces that they need in order to be able to prescribe treatment if their patient is positive. Remember, pharmacists are really champions. They can help the prescribers with treatment. This is not up to the psychiatrist to be able to do it on their own. There is a whole team of people who can help. On-site support is really important. So I support all the initiatives within our hospital. People know they can email me with questions, but importantly, we have a backup from the Toronto Centre for Liver Disease, and Dr. Jordan Feld has really been there for us. And that's it for my presentation. So I will stop sharing.
Thank you so much. I love that. This is doable. And what a fantastic message to start at the beginning in our first presentation. It really is doable. And I loved seeing the journey and how quickly you guys got to where you are now, which is just fantastic. We're going to move over to, hopefully, Professor Christoph, we're just going to do a quick double check to see if your mic is working now.
So unfortunately,
I try. And now. Yes. Okay.
Yes. There's a slight echo, but I think if you turn the other one off.
Yes.
Oh, Patricia's here. Thanks. I don't know if you can see that, Renee. Patricia is one of our previous board members. She's saying fantastic work. That's
okay. Now is it okay?
Yes, that's brilliant. Okay.
So I'm ready to speak.
Yes, it gives me great pleasure to introduce you to Professor Christoph Christa. He's going to talk about mental health addictions, dual diagnosis, and hepatitis, integrating mental health and liver care. Over to you.
Thank you very much. I represent Medical University of Silesia in Poland, and I like to say a few words about integrating mental health, addiction, and liver care for hepatitis B and C. So chronic hepatitis is really an isolated condition. Psychiatric and addictive disorders are frequently companions. Only by merging these domains can we address adherence, relapse prevention, and true quality of life. Next slide, please. Integrated care is more than coordination. It's a philosophy of connection. When systems unite, patients recover not just from disease, but from fragmentation itself. Next slide, please. Evidence shows that mental illness and substance use reduce treatment initiation and cure rates in hepatitis. Integration bridges this divide, aligning psychiatric stabilization with antiviral success. Next slide, please. Integrated care means shared protocols, synchronized communication, and multidisciplinary decision-making. It shifts focus from organ-based treatment to whole person management anchored in teamwork. Next slide, please. Depression affects up to 1/3 of chronic hepatitis patients, often preceding decompensation. And recognizing it, treating psychiatric symptoms early directly improves biologic and behavioral outcomes. Next slide, please. In fragmented systems, patients shuffle between clinics without continuity or ownership of care. Integration replaces this disjointed structure with a coherent network where information and empathy flow both ways. Next slide, please. Barriers such as stigma, access, and side effects are not patient flaws. They are system failures. Simplifying pathways and embedding support services transforms adherence from chance to strategy. Next slide, please. Each model offers a different route of the same destination. Collaborative continuity, co-location strengthens relationships, while telehealth extends reach to underserved populations. Next slide. One-stop clinics reduce attrition by turning multiple appointments into one coordinated encounter. This practical design increases patient trust and keeps treatment momentum alive. Next slide. When hepatologists, psychiatrists, nurses, and social workers coordinate in real time, treatment barriers shrink. Third rounds and case reviews create synergy far beyond the sum of specialists. Next slide. Consultation-based models are crucial for regions without full integration capacity. They turn specialist input to scalable solutions, mentoring frontline providers to manage psychiatric complexity. Next slide. Integrating antiviral therapy within opioid programs transforms access for marginalized groups. It proves that recovery and viral clearance can progress in tandem rather than in sequence. Next slide. Telehealth enables continuity for patients balancing stigma, poverty, and distance. When digital tools meet clinical empathy, geography stops determining prognosis. Next one. Integrated services convey that hepatitis, mental illness, and addiction are medical conditions, not moral defects. Normalization with healthcare spaces rebuilds dignity and engagement. Next one. Integrational bodies now advocate integrative frameworks across hepatology and psychiatry. The challenge is not lack of policy, but translating policy into everyday practice. Next slide. And coming to conclusion, training, digital tools, and reimbursement reform will determine whether integration scales beyond pilot programs. The next decade must turn promising case studies into standard operating systems. Thank you very much for your attention.
Fantastic. Thank you so much. And I think a really similar message there, integration and meeting people where they're at. And I love that, translating policies into practice. The policies are there. So there will be an opportunity. As I said before, please, if you've got questions, just pop them in the box because we're going to have to be open for some questions. But before we do that, it gives me pleasure to introduce you to Dr. Anastasia Sikora, who's going to talk about mental health professionals in hepatitis care, gaps, risks, and opportunities. So over to you, Dr. Anastasia.
Thank you, Rachel, for introduction. And I will share my presentation. 1 second. Okay, can you see my slides?
Yes, we can see them. Thank you.
Okay, thank you. Today I'd like to give a short clinical perspective on integrating hepatitis care into psychiatric services, with actually reflections from both Polish and Ukrainian contexts. And As you can see here, the prevalence of hepatitis C is significantly higher among people with severe mental illness, from 6% to even 70%, compared to just 2.3% in the general population, and that's 7 to 10-fold increased risk. And yet, psychiatric hospitals are often overlooked when it comes to screening or initiating hepatitis treatment. But in fact, these settings offer regular contact with high-risk individuals, many of whom have no access to traditional liver care. So the good news is that modern antiviral treatments, the so-called DAAs, are safe and effective even for patients with mental illness. They don't worsen psychiatric symptoms, unlike interferon-based treatments in the past. And you can see that the gap we see is not in medications, but actually in access and in systems. When treating patients with both hepatitis and mental illness, drug interactions are a serious concern. Many of our patients are on antidepressants, mood stabilizers, or antipsychotics, and when we introduce hepatitis treatment, especially antivirals, we must carefully monitor interactions. Even though modern DAAs are safer, combining them with psychiatrical medications can sometimes affect liver metabolism, increasing side effects, or reducing efficiency. That's why collaboration between psychiatrists and hepatologists is crucial. And in my experience, both in Poland and Ukraine, we often lack structured communication between specialists, and that puts patients at risk. We need clear protocols, shared responsibility, and cross-specialty teamwork to ensure safe and effective care for these patients. Okay, also about safe and modern treatment. As psychiatrists, we are involved in every step of hepatitis care, even if we don't always realize it. First, we can identify at-risk patients during our standard assessments, especially those with substance use, homelessness, or prior incarceration. Second, we play a role in referral coordination and treatment planning. In many psychiatric hospitals, we are often the only regular medical contact for our patients, and that's a responsibility. And third, our patients often need adherence support, especially those with cognitive deficits or comorbid conditions. We can help them navigate appointments and side effects, even talk about stigma. And finally, in long-term care, we are often the ones monitoring both mental and psychiatrical health, including relapse. In both Ukraine and Poland, I've seen how psychiatrists can act as bridges, connecting isolated patients with somatic care and public health services, but we need better tools, training, and collaboration as well. About roles of psychiatrists. So as psychiatrists, we are uniquely positioned to support patients with hepatitis across multiple levels of care. We can implement routine screening during psychiatric visits, even just asking about risk factors or offering a quick test, and it actually can open the door to treatment. Second, we need to provide a clear, simple education about hepatitis. Many of our patients may not understand transmission, the risk of untreated infection, or how treatment works, especially if they are in crisis or have some cognitive symptoms. Our role in harm reduction is essential also, whether it's counseling on substance use, clean needle practices, or reducing risky behaviors. We can do this in a supportive and non-judgmental way. And finally, we can't ignore social determinants, housing, food insecurity, stigma, transport issues. All of this affects whether our patients even make it to their hepatitis appointments. In the pre-treatment phase, our job as psychiatrists is really about coordination and preparation. We need to connect patients with liver specialists like hepatologists or infectious disease doctors and follow up to ensure they actually attended. Second, it's important to coordinate with the treatment team, psychiatrical history or active symptoms, complexity of hepatitis treatment. Then always check for drug interactions between hepatitis meds and psychiatric medication. Adjust doses if needed or consult a pharmacist. And finally, let's reduce social barriers. If a patient can't afford meds, doesn't have housing, or a lack of transport, they won't adhere to treatment. So we often help connect them with social workers or community support. And my takeaway messages to close, the first, it's mental health professionals must be fully included in hepatitis care from screening to follow-up. Then screening, coordination, and patient education should become like routine in psychiatric settings. And third, collaboration saves lives. Joint care leads to better adherence and outcomes. And finally, for global elimination, we must integrate liver and mental health services, especially for vulnerable populations. So thank you for your attention. Okay.
Fantastic. That's fantastic. And I love your last slide there, remind the gap. And what was it say? What did it say on the last slide there? Mind the gap and bridge it. I love that.
Yeah, yes.
Yeah, integration. And I think we all know that. And absolutely, it's about treating the person as a whole. We have a few questions now for the panelists. I don't know if are you there? Brilliant, fantastic. Renee's there. There we go, fantastic. So let's have a look here and see. So just kind of thinking back, and there is an opportunity for you in the audience. If you have any questions, please pop them into the box, or you can put your hands up in a minute. But Dr. Renee, I was wondering, what was it that why was it that you guys in Ontario decided to integrate hepatitis? What drew your attention to it? Apart from the fact Jordan there.
So it wasn't just one thing. I mean, when I started working caring for the patients on the inpatient units here about 10 years ago, I noticed that my patients were coming and telling me they were aware they had hepatitis C. They knew they had it, but they'd been told that they couldn't have treatment for it. I started referring them to the liver clinic. And then over time, I was very fortunate to have Dr. Jordanfeld reach out to our institution and say, you know, there's a real gap. And thanks for your referrals, but no one's coming from your institution over to ours to get their treatment. And maybe we could work together. And really that was it. So we started to work together to develop one, to bring an academic lens to this problem that I was just kind of seeing on the unit, and to understand the needs and how we could best fill those needs at the hospital. And it's really gone from there. So it's kind of exploded over the last few years. There's great awareness, and the projects that keep coming are really because various psychiatrists have reached out to me to say, I hear you doing this work. Can we do it over in my area? So it builds.
Yeah, it does build, and you know, and point of care is a game changer. But I'm curious about on your slide, you have the group of people that dropped out because they didn't, exactly what you're saying, the reason why you're doing more insight. Have you guys thought about introducing some kind of peer support where people who were leaving perhaps were supported to go to the services outside of the hospital?
Yeah, that's a great question. And yeah, so my next quality improvement project, we're actually going to look at that. We're going to bring peer support into that project to see if that makes a difference, specifically for patients who have schizophrenia, to see if that can help to get them to treatment. So the screening with the point of care test can happen, but then, you know, people fall off that, what we call the cascade of care. So they screen, they know they're antibody positive, but the next step is to get the blood test. So how do you get to the lab? Some people drop out there. Once you've been diagnosed with hepatitis C, we know we can treat it people need someone to treat it. Even if we're treating it here, they may be concerned. There's stigma and all kinds of things. They may not want it. They may be very concerned that their psychiatrist, who I'm training the psychiatrist to do the treatment, their psychiatrist suddenly wants to prescribe a medical medication. I mean, there's certainly precedents for that at our hospital. Many of the psychiatrists prescribe metformin and semaglutide for metabolic effects of antipsychotic medications, so they can treat some medical issues. And so we would like to see this happen, but I think a peer support would go a very long way to help our patients feel more comfortable in doing the treatment and understanding why the treatment is important.
Yeah, and you know, we know that, you know, lived experience helps people walk them through that journey, particularly when they are people who have more complex needs.
Yeah.
Yeah, it's that identification. I have so many questions for you, but I do need to ask Dr. Anastasia another a question as well. Dr. Anastasia, are you there?
Yeah,
Yeah,
I'm here.
Yes, I just wondered, I wanted just kind of a similar sort of stuff. I just wondered how, you know, in the work that you were talking about, what are some of the barriers that prevents people with, in your experience, the people that are accessing the services with mental issues, what
Yes,
prevents them from being screened or treated for hepatitis?
Actually, yes. In my experience, the biggest barriers it was, as I told, like the stigma about our patients. It's lack of knowledge and like no formal screening protocols. Like we don't have them, and many psychiatrists we actually think that it's still not our job, yeah, to screen this kind of patients and to treat. Patients who have hepatitis, and patients, especially those with addictions and trauma, they often mistrust the system and they just avoid testing because they don't believe it, they don't want to do this, and though again going back to the stigma problem.
Yeah. When we had our community group, stigma was really high. You know, that when everyone was talking about mental health, and actually the World Hepatitis Alliance was involved. It did in a survey, a stigma survey, which we did with ECDC, and stigma is huge. Absolutely huge, you know, kind of the impact that it has on people, not just on people's mental health, but I guess on telling your support system. So there's a lack of support system around you, which if you have mental health issues on top, it just exacerbates everything. So yeah, stigma is huge. I guess the one other thing I wanted to ask you both was around consent. It's not one of the questions that's listed here, but I was thinking as I was listening to you both, particularly Renee, if you're, you know, you've got someone coming into a secure unit, how do you or do you have to go through consent? Because it's about people being able to understand exactly what's happening and having autonomy in. And I wonder whether other professionals have that as a query, you know, in terms of if someone's got a severe mental health issue, is there an issue around consent when you're talking about treating viral hepatitis at the same time?
Yeah, I mean, I think, you know, one of the, when we think about the different barriers for patients, there's patient factors, provider factors, and system factors. And certainly one of the patient factors is the illness itself and how it may interfere. I mean, we have to get consent, right? That's what we do. So that's the bottom line. But even if a patient is not capable of consent in the moment, you still try, you still provide the education, you provide the information, and then you come back. So there's another opportunity. So to shy away from something because we fear that our patients might not understand doesn't make sense to me. We still have to approach the patient and see. I mean, I have patients who are incapable, deemed incapable from a psychiatric perspective, but are quite capable to consent to, for instance, a COVID vaccine, a flu vaccine, screening for STIs and bloodborne pathogens. So we have to remember that consent, we have to get consent for each thing that we're offering the patient. It's not a blanket. And so it's really important to have these conversations, and we owe it to our patients to have these conversations.
100%. Yeah, Dr. Anastasia.
Yeah, about like signing the consent form in Poland, or how it was actually in Ukraine, it was the same. So admitting to the psychiatric hospital, they should sign the consent form, and it is listed all the procedures, yes, we are doing here, and all like that we are giving them medication, that we are testing like some like simple blood tests, laboratory diagnostic. So, and it was like, as I told, we have no protocols for testing on HCV or HCV, yes. So there were, I never saw something like consent form for testing for the hepatitis C or B. But I think it's something that we should develop, yes, and give the patient that, as the Renee told, that maybe they don't want to give the consent to be treated psychiatrically or in a psychiatrical hospital, but they would like to be tested, so they can sign this kind of form. Yeah, it's interesting. Thanks.
Yeah, I've got more questions for you both, but we have to give the audience an opportunity. I've noted if anybody's got a question they want to speak, please put your hand up. While you're thinking about that, there's a couple of questions in the Q&A. So there's one from Megan. It says, I've been really interested in what happens after cure. Mental health often improves once hepatitis C is cleared, but not always. Do we have a good understanding yet of whether that's down to biological factors like lingering inflammation or immune changes, or more to do with people's mental health history and past experiences? Great question. Anybody want to have a go at that?
Renee?
Yeah, so I don't know that we know the mechanism. I mean, I think my understanding from my reading is that there is an association. So, so patients following treatment, report that their mood may be improved, their energy may be improved, and these are important things for patients to be aware of. But I don't know what the biological basis for that might be, and I don't know that that's known.
I can tell you from my own personal experience of having hepatitis C, but I mean, I didn't do the new treatment, I did the interferon. And I was very, very low before I was treated. In fact, the reason I chose to go for the interferon, irrespective of it being so harsh, was because I was so unwell. And there was, after a small amount of time, there was a noticeable difference. I mean, we don't there are enough people, there's no medical evidence to say that hepatitis gives you depression, but there are enough patients that tell you, yes, it does. Hepatitis C, definitely. So my own personal experience was following treatment and cure, not straight away, but absolutely. My mood was far more balanced and I was able to engage better in life. So, but I can't give you the physical thing. There's another question.
Yeah, I can also think that if connecting between mental health, like pathophysiology and pathophysiology of hepatitis, we for sure will have the inflammation between, like inflammation that occurs in both of this. So, and when we are given antidepressants or we are given DAA drugs, we still reducing the inflammation in the body of the patient. So, like the connection is always like persist, but still we need to find maybe more evidence based.
Yes, Renee.
Just one more thought on that, that I always consider when I see my patients who have bipolar illness or schizophrenia. The burden of illness for this population is huge. So not only the severe mental illness, but all of the other medical conditions we know that they're at higher risk for. So metabolic issues, cardiovascular disease, and hepatitis C is treatable and curable. And boy, my patients who have completed the treatment, it's one burden less. So that also is not a biological impact, but it certainly may be a psychological one, and it can be quite empowering for patients.
Absolutely. And I think just in with that as well, if somebody, there is growing evidence around somebody who's in addiction who does take responsibility and ends up going through the hepatitis treatment, it triggers a whole journey of changing their lives. exactly the same reasoning as you're saying. There's quite a few questions coming in now. Oh, goodness me. Okay, so what have we got here? So we know that hepatitis C virus can affect people's cognitive function, but I'd like to know if people infected with the virus can show noticeable changes in their behavior or mood before developing cirrhosis, and that doctors can consider looking for hepatitis C as a possible cause in case liver function tests also show, I can't actually see all that, some alterations. I don't know if you guys can read that as well. It doesn't really make sense as I'm saying it. No, just people's change can noticeably changes their behavior, mood, developing cirrhosis. I mean, I wonder with this whether what Antonio is talking about there is encephalopathy, and when your liver is, the more cirrhosis your liver becomes, you then got toxins going to the brain. Maybe that's the connection there, rather than, because that does have an impact on the mood. The more a liver deteriorates, you run the risk of encephalopathy. You guys as clinicians, physicians would know more than myself.
Yeah, I'm not sure what the question is, but the cognitive function, I don't know, in relation to severe mental illness. I mean, the cause may or may not be the hepatitis C, but hepatitis C certainly may exacerbate, as we just talked about. After treatment, people improve energy, improve function. But I think what we do know is that everyone with severe mental illness probably should be screened because the prevalence is much higher than the general population, depending on where you are in the world. But I think overall, severe mental illness as a standalone risk factor is higher. And so that group should be screened irrespective of their liver tests. Their liver tests their ALT, their liver enzymes may be entirely normal, their liver function may be normal, but they may still be experiencing some impact of their hep C. And certainly if we don't screen and test for it, they will be suffering later on if we don't get rid of it. So I think the important thing is to remember high prevalence in this population should be screened for, can be treated and cured, and preventing future morbidity for our patients.
Fantastic. There's a great question here for both of you. What have been the biggest logistical barriers to integrating hepatitis C into psychiatric services, and what have you done to overcome these? Great question. Actually come from where I work, so from the Hep C Trust. But over to you two. Yeah, what do you think?
Okay, as for me, like, you mean when I have patients and logistically to call other professionals, I mean specialists, infectious disease, for example, it was always like hard here in Poland and also in Ukraine to find the term for patient to come for the consultation. So I was like calling every time, asking that I have this kind of patient and he needs, for example, treatment. He is already diagnosed with hepatitis, but still it was always like we have no place to write him to the schedule or something like that. So please, when he is discharged from the psychiatrical hospital, so he can go and wait in a line to be admitted, yes, to another hospital or to the ambulatory hospital. So actually, this is the problem in like navigating patients from one hospital to another, or to asking them for some consultation. It was a little, I have like the example about AIDS patients. It's easier because here in Poland, in Warsaw, it was easier just to call them to tell that I have this and this patient, to give his like history that what he's doing here, and they were ready for us, like for psychiatrists, send them the for example, the nurse to take drugs for this patient and come back to our hospital so he can continue treatment in the hospital. So it would be great if something was hepatitis C and B treatment we can adjust like this in a psychiatrical hospital. So to consult by the phone, to consult with the specialist online, and to ensure the treatment for the patient with comorbid hepatitis, for example.
Yeah, so I mean the barriers to sending people out are just so high here, and so what we have opted to do is to bring the treatment here, but there are still barriers. So getting people to incorporate Hep C screening into their routine practice. Less of a problem on the inpatient units because the hospitalists were already in the practice of doing this. But in the addictions clinic, for instance, and the challenge may be in the schizophrenia clinic to get people to do it. So how have we overcome it? We've brought the point of care tests and we've trained nurses to do it. So nurses can do pre-test and post-test counseling and perform an antibody test. And then you've screened everybody. You've screened everyone. You know if they're negative, that's it. The end. Now we just talk about, post-test counseling and harm reduction. But if they're positive, then they can go on. So they kind of screen for the physicians, the patients who they really need to see and focus on. We overcome it by providing as much education to nursing, allied psychiatry as we can, and provide support. We have to provide support. And yeah, I totally agree. I mean, the peer support piece is a piece that we have been missing at CAMH. So I am currently filling out an application to bring that on board so that we can have peer support in our hospital, because I think that that's needed for the patient side to provide them with support.
Fantastic. I'm a huge advocate of peer support. I believe this is a whole system approach, and it's about all of us working together, including lived experience. I've just realised the time. I'm quite happily have got so many questions, but actually we have 2 minutes left. So I'm going to hand it back to you guys. And just for anybody in the webinar, I'm sorry if we haven't got to your question, and to say that that Dr. Christoph unfortunately had to leave, so I didn't say that in between. But just over to you guys. One last question, same question to both of you, quick answer so that we've got time. If you could issue one call to action to mental health professionals worldwide regarding hepatitis care, what would it be?
One call question. I think if I can ask for one call questions, I will.
One call to action. What would it be?
Yeah, just that we need to screen every psychiatric patient for hepatitis risk.
Fantastic.
Yeah, and my call to action would be consider the success of on-site screening and treatment, and to promote the training of hospitalists, psychiatrists in providing the care where patients arrive, when they arrive in a facility. It may be their only touch point with the healthcare system, and so it's time to do the screening.
Yeah, it's so spot on. That is the thing, isn't it? If this is the only place where people are going to be touching the healthcare system, we should offer everything, absolutely everything. It has been such a pleasure to be here with you both. I'm so sorry we don't have any more time. I can't believe it's gone so quickly. And hopefully it did go quickly for you guys as well. It zoomed by for me. Thank you to everybody who attended the webinar, and I'm sorry we haven't had more time to discuss more, but it's been an absolute pleasure. If you want any more information on No Hep professionals, please do follow the QR code. I wonder, Ben, can we put the QR code up again? Please, if you are a professional out there listening to the webinar and you would like to become a No Hep visionary, all the instructions are through the link on the website. Have we got that slide, Alexandria? That's it, yes, just where the QR code is. You can find any more information about the No Hep visionaries, medical visionaries, on our website. Yeah, fantastic. Integrated, working together. What a great webinar. Thank you so much for all our attendees, our panelists, take care, and we'll see you again soon. Thank you.